Hello everyone, thanks for tuning in. My name is David Stein and I am a colorectal surgeon and I'm going to be talking about screening for colorectal cancer. One of the things as a friendly reminder, please log in to YouTube, and if you've signed up for this event you can use the chatbot feature to ask questions or post ideas or comments as these presentations occur. So with that being said, where do we start? How does one talk about colons and cancer and screening? And I'd like to start with a fictional character, Mrs. Smith. Mrs. Smith is a 48-year-old female. She's busy. She has 3 teenage kids. She runs around. She has a part-time job, coordinating their schedule, her own schedule, crazy life. She kind of noticed over the past few years a little bit of blood in the stool. She would wipe after having a bowel movement, a little spot here, a little spot there, figured it was a hemorrhoid, ignored it. 3 months went by, 6 months went by. She showed up for her GYN appointment, routine screening, and they asked her, as they were doing the pap smear, anything else going on? And she said, you know what? I do see blood when I have a bowel movement. I said, okay, that's interesting. And in the office, they did something called a guaiac test, which is a way to measure how much blood is in the stool. That came back positive as well. And based on that, she went and got a colonoscopy. The colonoscopy that was performed was diagnostic because there was rectal bleeding, and they found in her sigmoid colon a cancer growing. So I don't want to talk about the treatment for cancer, but if we focus on Mrs. Smith, who's a 48-year-old female who is completely asymptomatic and really just sees spotting of blood, is there something that she should have been doing to ensure that she doesn't develop colon cancer, rectal cancer, or colon polyps? And that is called screening. Screening, by definition, is a test that we offer when there are no symptoms present. Most classically, and you will hear about some of these today, mammography for breast cancer, colonoscopy for colon cancer. Those are the classic screening tests we use, meaning I don't feel anything, I feel great, life is wonderful, but lo and behold, I get a test to ensure there's nothing happening in my body. And with screening tests, the whole key is the age at which we're supposed to start screening. So historically, everybody heard at age 50, I go get my colonoscopy, I get screened for colorectal cancer. But we lowered that age a few years ago. The American Cancer Society guidelines in 2018 actually lowered the age for asymptomatic screening, average risk people, to age 45. So Mrs. Smith, who at 48 was having symptoms, really should have had this done 3 years earlier. And that may have prevented a tumor from growing over those years. So what are the screening tests we can discuss? There's different kinds, and we're going to start with the least invasive, and on many levels the most awkward, to the most invasive, which, even though it's still awkward, it's less awkward because you get to go to sleep. So the least invasive test is actually looking at the stool itself. In the stool, if we have a polyp growing or a cancer growing, we start developing bleeding. And as the tumor gets bigger, the lining of the inside of the colon starts shedding blood. That hemoglobin, the breakdown of the blood product, or the actual blood itself, can get detected in stool. And there are 3 tests, or really 2 types of tests for the purposes of detecting blood and blood-related proteins. Tried and true, been around since the 50s, is a guaiac test. Guaiac is a chemical that binds with heme, iron, which is a breakdown of the red blood cell. And fecal occult blood tests, which is what we call them, you're looking for hidden blood. You don't actually see the blood, but it will pick up iron, which is a breakdown of the blood product in your stool. Now, you need, in order to do this, you can do it at home, multiple samples. So meaning you go in and you actually poop in a little package that holds it, and you poke the stool, and you're supposed to do 3 consecutive bowel movements, and that gets sent to a lab and they develop it. And if the developer shows there's iron, that means you should go ahead and get referred for further investigation, such as a colonoscopy. The next level up, also at home, similar, is called a FIT test, fecal immunohistochemical testing. A FIT test detects the actual human blood in the stool. So what happens when that occurs is same sort of thing. You don't need multiple stool samples. You move your bowels. Again, there's some mechanism to keep the stool contained. You poke it, send it to the lab. It gives you a result. Positive, you need further workup. Negative, you're okay. So if you're doing these tests every year, you should be able to determine whether or not you're at risk for a colon cancer growing. If there's no blood, the risk of colon cancer is significantly low. So what's the difference and the nuance between the two? Because fecal occult blood testing is required to look for heme, if you're eating a lot of red meat, you can make it a false positive. Certain food groups, certain other things also can make the test positive. And as I mentioned, you need multiple testing. There is a higher false positivity rate with fecal occult blood testing than there is with FIT testing. So most people are recommending FIT testing, which again is made by many different companies, and you can get it in pharmacies and in other locations. FIT testing, because it detects the actual blood, has a lower false positivity rate, but the sensitivity rates, you get a positive test when disease is present, are similar. The next level down is called multi-targeted stool DNA testing. That's a lot of words, but basically you're looking at the stool and you're sending your actual stool to a lab. They send you a little mini bucket that you put in your toilet, in your commode. You poop in there on dry ice and the sample gets sent off to the lab. And what they're doing there is they're looking at the DNA in the actual stool. And it's crazy when you think about it, but if you have a cancer growing, we know the most common colon cancers and rectal cancers that exist. And when you have these tests, they look for the common DNA particles. And if they see that, also it's positive, you get referred for a colonoscopy where they go ahead and make sure there's nothing there. So the three stool-based tests that exists, again, are fecal occult blood testing, about 80% sensitive at detecting, blood in the stool, FIT testing similar, and multi-targeted stool DNA testing, which is actually a little bit higher, 88%. Again, the fecal occult blood test and the stool testing do have a higher false positive rate, which means that it's positive even though you don't have any disease. From there, we get into what we would call structural examinations. Okay, we looked at the stool, but now we're going to look at your colon wall structure. And there are two ways of doing that. Way one is what we affectionately call a virtual colonoscopy. And what this is imaging. Different kinds, you can do MRI-based or CAT scan-based. You still need a bowel prep. You still need to clean yourself out because the stool will show up on the imaging. But the concept is instead of putting a scope inside you, you use imaging to detect if there's any lesions or growths or cancers in the colon. So a classic virtual colonoscopy is a CAT scan-based test. You clean out as if you would a normal colonoscopy. You come into the radiology center. It's an X-ray test. They put a little catheter in your bottom, in the rectum, and they inflate the colon with air. And when they do this, they distend it. So the collapsed tube goes like this, and the imaging looks for little growths inside. So if this is a normal lumen, nice and smooth, but they see something like this in the way that hasn't been cleaned out, that could be a cancer there. And if they detect that, that would be a referral for colonoscopy. And I don't know if you have been detecting the theme, but the theme is if anything else is positive, you get referred for a colonoscopy. So what is a colonoscopy? It's also considered a structural examination. And a colonoscopy is designed to go inside the colon, and the operator, someone called an endoscopist, which can be a gastroenterologist, in some places a family practitioner, a colorectal surgeon, a general surgeon. The endoscopist goes in and actually looks for him or herself at the wall of the colon. As they go in and look at this, they're detecting not just the structural views, but any growths or lesions. The biggest advantage of a colonoscopy is that at that time, they can also remove a polyp. They can biopsy a cancer. So in addition to being diagnostic, it can also be therapeutic, meaning we've diagnosed a problem, but now we can also treat it. So an early polyp that hasn't turned into a cancer yet that can be treated. And if there is a cancer there, we know where it is and we can get the tissue biopsies, which help determine normal therapy. So the downsides of a colonoscopy, you need the prep, like a virtual colonoscopy. And often most folks want anesthesia with it. And in many places they will give sedation. So you get to take a nice nap and get your scope done and then you wake up. So on many levels it's the least awkward of all the tests because you're not messing with the stool or anything like that. But it is the most invasive in that we're putting a scope inside of you, we're giving you anesthesia, you're going to sleep, you need somebody to come with you. And you need the bowel prep as discussed. Of all the tests, colonoscopy is what we would consider the gold standard. It has the highest detection rate for polyps and cancer among all the other tests. But I think the theme here is it's much more important to get a test done than to worry about the specific test done. So if you asked me at my age, what have I did? I got myself a colonoscopy when I turned 45, even though it was a while ago. And then the next question is, well, if the colonoscopy was normal or the testing doesn't show any cancers, do I need another test? And the answer is yes. For colonoscopy, it's every 10 years to make sure that nothing new has grown in that interval. For the stool-based testing, it's for the fecal-occult blood and the FIT testing, that's every year. And for the multi-targeted stool DNA test, that's every 3 years. So you can pick and choose a little bit of your personal poison as to what gets you excited about making sure you're maintaining your health. Is it a stool-based test or a structural exam with a virtual colonoscopy or a colonoscopy? And based on those things, you can determine next steps. So let's rewind a minute. Why is it so important for Mrs. Smith, you remember, who at 48 had been ignoring symptoms for 3 years, to have gotten her scope? Well, let's say at 45 she went for any one of these tests and they picked up positive blood or a lesion growing. She could have had a polyp removed because the pathway from abnormal cells to polyp growth and the polyp that's growing turning into a cancer can take anywhere from 3 to 10 years depending on the studies you look at. Which means the 10-year interval makes sense, and which means that if we start screening at age 45, it's incredibly important to just be thorough, get a test done, and get yourself screened. One little piece is that's average risk. There are certain people who are at higher risk. I have a first-degree relative, a mother, a father, a sister, a brother, a son, or a daughter who has had a colon cancer. I'm in a higher risk category. And for those types of people, if you fall into that category, you should talk to your doctor about the ideal screening interval. What we discussed so far is really just about screening in asymptomatic average risk people. And the most important thing is get yourself screened. Age 45, talk to your physician, figure out the best test for you, and go get screened. Because we have really good ways of treating colon cancer, and early detection leads to very high survival. And for the inconvenience of getting a test, it's really quite silly to die of colon cancer. So with that, I thank you for your time. And again, hopefully you've been sending questions through the chat bot function, which is kind of a new world that we all live in. Have a wonderful day.